small topic. Still there are 50 plus lines. LDL management beyond statins by Bempedoic. So, per se, the prevalence of dyslipidemia is very high. This is quite old study published in 2014, phase 1 of ICMR India B study, which showed that hypercholesterolemia nearly 13.9%. Nearly 13.9% hypercholesterolemia, hypertriglyceridemia found in nearly 30%. High LDL nearly 11.8%, but the study was done only in Maharashtra, Tamil Nadu, Jharkhand and Chandigarh, so not representing entire India. Is the dyslipidemia harmful? Yes, the multiple studies has been shown that dyslipidemia is harmful. One of them is ERIC study, which showed that by increasing 1 millimole per liter, that is 38.7 milligram per deciliter increase in LDL cholesterol, increased cardiovascular risk by nearly 40%. And there are multiple drugs available to treat dyslipidemias, including statin, fenofibrates, ezetimibe, icosapentethyl, bempedoic acid, alirocumab, uvalokimab, and inclisiran. Out of that, today we will discuss bempedoic acid. Someday, if time permits, we will discuss icosapentethyl also, because that's a newer molecule coming into the practice. Now, various studies have shown that nearly 80% of patients who are treated with statin do not achieve LDL goal. If we look at only this one study, patients who are having diabetes mellitus, nearly 42% of patients does not achieve LDL goal, and 10% risk remains high, as high as 50% in this.
Yeah, LDL is not goal curve. 170, 55.
77.
I'll say.
77. And this study has shown the probable reason also. First reason was high baseline LDL. If you look at the second reason, aggressive LDL-C treatment goals was the reason. With changing in guidelines, the LDL-C goal has also been changed by multiple guidelines, and that is also one of the reasons why patient could not achieve LDL-C. Like in past, LDL goal was 120. It has been reduced to 100, it has been reduced to 70, now it has been reduced to 55. So that's why majority of patients are not able to achieve LDL-C goal.
Again, there are two classes of patients.
Yes.
One class of patient where patient is an infarction.
Yes.
Or
Primary disease, secondary.
or any vascular disease in the body. Another group is just on routine screening, they are finding high hypercholesterol.
Yes. So that is for primary prevention. The non-health checkup
Here
found that LDL is
are
high.
talking secondary prevention.
No, I am talking about both. We will come to both the parts. So and another reason for using such non-statin therapy is one of the reasons is statin intolerance also. Because of statin intolerance, patient could not take maximally possible dose of statin, and they tend to stop statin, they tend to stop therapies, and that's why they could not reach the target. And in general practice, the incidence is not very high, it is only 1 to 2%.
Yes, see, in practice, I give more 40 milligrams is my routine prescription. Routine prescription.
So
I don't find
Indians.
any problem in.
Yeah, in India, statin intolerance is very low. This is worldwide, it is 1 to 2%. In Indians, hardly.
You will label it as only clinical. Patient myalgia or fibromyalgia.
Yeah, only clinical. But later on, if you get the SCOT, SGPT and CKM done,
It will more than 3 times normal,
Yes.
upper normal.
So like as an example, one patient comes to you, says I have leg pain. We do suspect that this is a statin intolerance myalgia. But majority of this patient, when you subject to CKMM, you won't find CKMM elevated. That leg pain can be related to something else also. Leg pain can be attributed to vitamin B12 deficiency, D3 deficiency, multiple other causes also.
Leg pain is very common.
Very common. And second cause of leg pain is patient was sedentary initially. Now we are asking him to walk and do exercise. That's why also he is developing some leg pain. So leg pain is not always because of statin.
Statin positive करता negative marketing बदल सकते especially GPs में.
But still, statin is first and foremost and important drug for kidney disease.
તમે ગામમાં લોકોને પૂછશો ને તો જે લેમેન છે काम ना के फायदो will take decades or even more than decades. But सामान्य side effect બીજા કારણથી થઈ હશે તો એને પબ્લિસાઇઝ થઈ જશે. તો આ લીધી એટલે દુખી ગયું.
So let's coming to our topic, that is bempedoic acid is a novel inhibitor of ATP citrate lyase. The mechanism of action. Bempedoic acid is a prodrug and it needs to be activated to active form, that is bempedoic-CoA, by A-serial enzyme. A-serial is a very long chain acyl-CoA synthase inhibitor enzyme, acyl-CoA synthase enzyme, which is found only and only in liver. And by doing so, bempedoic-CoA, the active drug, inhibits ATP citrate lyase, ACL enzyme. ATP citrate lyase converts citrate to another molecule which eventually gets converted to cholesterol by HMG-CoA reductase enzyme. So, by saying this, I mean to say that bempedoic acid acts 2 steps ahead of where statin acts. Statin inhibits HMG-CoA reductase enzyme, while bempedoic-CoA inhibits ATP citrate lyase, which is 2 steps above the HMG-CoA reductase enzyme. And by doing it reduces cholesterol synthesis, it increases LDL receptor upregulation, and it inhibits serum concentration of LDL cholesterol. Another point to note is bempedoic acid also inhibits OAT2 enzyme. OAT2 is organic anion transport enzyme, and OAT2 enzyme excretes uric acid and creatine. So when we are talking about OAT2 inhibition, uric acid and creatinine concentration increases inside the blood. And that's why many times after giving bempedoic acid, we do find that asymptomatic increase in uric acid has been noted. It has been noted in studies also, it has been noted clinically also. Although gout has been noted in some patients, but it's not clinically significant. Another important point is this ACL enzyme is absent in muscles, and that's why it has been postulated or hypothesized that bempedoic acid has least muscular side effect when compared to statins. And it has also been studied that when patients who are on bempedoic acid, when plasma was taken from that patient and bempedoic-CoA concentration was checked, that is active drug concentration in plasma was not found in plasma of patients who are on bempedoic acid. So it means that this active prodrug does not escape hepatocyte at all. And that's why this active, it's not chances that active prodrug will go to muscle and then it will inhibit ATP citrate lyase and have a muscular side effect. So that also is not going to happen. Bempedoic acid per se does not have any side effects related to muscle. Still, some of the patients will complain muscular pains.
Because they just know our cholesterol in medicine.
Yes.
They are not aware what is
It's a
statin.
placebo type of side
Yeah.
effects. Pharmacokinetic, there is no food interaction on oral bioavailability. Median time to reach maximum concentration is 3.5 hours and steady state reaches after 7 days. 99% of drug is plasma protein bound and it gets eliminated by glucuronidation, and this glucuronide conjugates will get excreted via liver and then eventually in urine. So 70% elimination is through urine, 30% through feces. There are no major drug interactions as it does not interact with P450 enzymes. Although it has been noted in previous studies that co-administration of bempedoic acid along with simvastatin and parvastatin increases plasma concentration of statins, and that can have a side effects. Weak interaction of bempedoic acid also has been noted with atorvastatin, rosuvastatin and clinically not significant. But still, yellow flag sign is that it should not be used along with simvastatin and parvastatin. What about clinical trials? There are 4 phase 3 pilot studies. One was Clear Harmony and Clear Wisdom, the blue studies, and that involved patients who are on maximally tolerated statin therapy but could not achieve LDL goal. And that study was done for entire year, 52 weeks. Versus 2 other studies, Clear Serenity and Clear Tranquility trial, that were done on patients who are on not maximally tolerated statins or who are statin intolerant. So they were on minimal possible statin therapy or not at all on statin therapy. And that studies were done for 24 weeks and 12 weeks. Clear Serenity also included patients who were on ezetimibe. So that discussion we will see. And when this 4 studies completed, after a year, the LDL-C reduction was as high as 15% in patients who were on statin. So beyond statin, and bempedoic acid reduced LDL by 15%. And patients who were not on statin or patients who were on minimal dose of statin, bempedoic acid was more useful and it reduced LDL cholesterol by nearly 25%. Beyond LDL cholesterol,
So that should mean that it cannot be held in primary prevention. Okay, તમારો ટાર્ગેટ શું હોય કે 50%
these patients were not for primary prevention.
આ તો એક ઇન્ડિજિનસ કોમેન્ટ છે. Suppose મારે as a first drug of choice bempedoic acid આપવું હોય તો probably it is not going to solve the issue.
Yeah, it's not recommended yet.
Exactly.
So beyond the LDL cholesterol reduction, now we are talking much more about inflammation. So LDL bempedoic acid also reduced inflammatory marker hsCRP by 20% in patients who were on statin and nearly by 25 to 30% on patients who were not on statins or on minimal dose of statins. So it reduced inflammation also.
અને absolute value આપી છે HSCRP ની આ ટ્રાયલ માં.
हाँ, absolute value आपी છે, मैं include નથી કરી.
very dicey slide because so maximally tolerated statin પર હોય ને તો HSCRP 5 થી 99% ઓછું આવી ગયું.
Already
તો એમાં 20% ઘટ્યું ને ના ઘટ્યું કોઈ doesn't make much difference, you know.
Yes. But this is placebo corrected difference. So
fully agree.
when you do corrections,
maximally તો આ પહેલા વાળામાં હજી આપણે ડિસ્કસ કરીએ કે મિનિમલ વાળા તો maximally tolerated statin વાળું પેશન્ટ નો HSCRP 2-4 પાસે જ હોય.
value આપી છે, मैं skip કરી દઉં તમને મોકલાવીશ value. Then come the clear outcome trial. Till now we were discussing trials which were only of phase 3 trials and not phase 4. Clear outcome published in 2023 was a phase 4 largest trial involving 13,900, nearly 14,000 patients. And the primary endpoint of this trial was LDL-C reduction by bempedoic acid was significantly high as compared to placebo. HSCRP reduction was significantly high as compared to placebo. This has been proven in previous trials also, pilot studies also. Major finding here was 4-point MACE rate, that is composite of cardiovascular death, non-fatal myocardial infarction, stroke and coronary revascularization. Bempedoic acid reduced everything by 13.3% versus placebo, which reduced everything by 11.7%. Statistically significant.
એક મિનિટ 11.7 bempedoic acid છે.
Yeah, sorry, 11.7 by bempedoic acid. That was the incidence rate.
Event occurred.
Event occurred.
So hazard ratio reduction કેટલો છે?
Hazard ratio is 0.87.
13% જેવું છે.
0.87 hazard.
NNT આપ્યું છે?
So NNT was somewhere around 32. આ સ્લાઇડમાં નથી, but NNT was 32.
So આટલું ઓછું hazard ratio improve હોવા છતાંય p value શું કામ આટલી
P value
significant?
0.001.
Why?
Significantly because of the composite endpoint છે ને ચાર કાર્ડિયોવાસ્ક્યુલર ડેથ એટલું બધું રિડક્શન નથી, ઓલ કોઝ ડેથ રિડક્શન નથી, પણ સ્ટ્રોક રિડક્શન છે, કોરોનરી રિવાસ્ક્યુલરાઇઝેશન સિગ્નિફિકન્ટ રિડક્શન.
So p value એટલે reduction છે આટલી વધારે કે તમારું સેમ્પલ સાઇઝ ખૂબ જ મોટું છે. That is the only reason કે આ p value વધારે છે. બાકી this could have never got such a high such a nice p value.
When everything was compared separately, 3-point MACE rate also reduced significantly with bempedoic acid, and fatal or non-fatal myocardial infarction reduced, coronary revascularization slightly reduced, but yes, it was also statistically significant. Effect on stroke, and that says it's an all cardiovascular drug. Stroke also reduced with bempedoic acid. And when subgroup analysis was done for clear outcome, bempedoic acid was more or less useful in all
Patient
subgroups.
characteristics શું હતું? આ high risk patient છે, low risk patient છે, કયા છે patient?
No, these are all high risk patients.
High risk
These
patient.
are for secondary prevention.
એટલે already ACVD હતું. Okay, then it makes sense. બાકી 5 જ વર્ષમાં આટલા બધા prevention કેવી રીતે?
No, secondary prevention. All
Secondary.
primary prevention ના trial બહુ નાના છે, આટલા મોટા નથી.
Okay.
And majority of patients in this clear outcome, nearly 52% patients were diabetic also, and 38 or 40% patients were
એમાં
hypertensive.
patient characteristic વાળું ટેબલ મૂક્યું છે તમે?
No. So, in all age group, gender group, baseline cardiovascular disease, Some primary prevention patients were also there, but with high this risk group were also included. Baseline LDL-C cholesterol, baseline HSCRP level in all groups. It was
Very interesting to see that in Western Europe they didn't found any good thing.
because of maybe it was a site related changes. Except in one group, age group beyond 75 it was neutral, and this group, BMI less than 25 it was neutral.
તો કઈ explanation આપે છે આપણે વસ્તુ?
વેસ્ટર્ન યુરોપની અંદર આવું થવાનું કંઈ કારણ કંઈ આપ્યું છે?
Then maybe there may not have given major sites in Western
આ
Europe.
સ્ટડી ક્યારે પબ્લિશ થયો? આનું પોસ્ટ હોક એનાલિસિસ આવી ગયું?
2023.
તો હશે ડિટેલ આની ઉપર બી બહુ બધી કોમેન્ટ આવી હશે.
છે આની ઉપર આખા presentations. Beyond these 5 trials, there were multiple meta-analyses published in 2023 and 2024. Efficacy and safety of bempedoic acid for prevention of cardiovascular events and diabetes. Diabetes I'll come to as a separate topic later on. But bempedoic acid as a composite cardiovascular outcome risk reduction by 25%, and reduction rate in new onset or worsening diabetes was by 35%. This is a controversial statement.
Oh.
That I'll come to that statement again later on.
એટલે જ એમાં p વેલ્યુ નથી લખી.
It's a controversial statement. કારણ કે બે સ્ટડીઝ એવી છે જેને હું બતાવ્યું છે કે diabetes rates are increasing with bempedoic acid. Rest all the studies, but diabetes rates are decreasing.
પેલા જુપિટર સ્ટેટિન જેવું છે એકમાં એક જ બતાવી છે.
Then another meta-analysis involving 11 trials, nearly 19,000 patients. All-cause mortality does not reduce with bempedoic acid alone. Cardiovascular mortality also does not reduce, but MACE rate, myocardial reinfarction, stroke, unstable angina, rehospitalization and revascularization rate significantly reduced. Gout significantly increased with bempedoic acid. Renal impairment also increased with bempedoic acid, and new or worsening onset diabetes less with bempedoic acid. So this was second meta-analysis.
Gallstone પણ વધી ગઈ છે.
Gallstone 6, cholic acid also increased.
વધે છે
આવું એનાલિસિસ આવે ને?
કેવી રીતે એટલે આ
So that
So
should be
cardiovascular mortality does not increase, it's neutral. When we look at these two lines, that is the standard deviation line. So it is in neutral range.
still it is in the plus side. So
Still it is on plus.
point is કે જ્યારે ડેથ ઇમ્પ્રુવ ના થતું હોય ને ત્યારે જે મોલેક્યુલ જે ક્વેશ્ચનમાં છે ને એ એકદમ એક માઇલ્ડ ટુ મોડરેટ એફિકેસિયસ હોય.
Yeah.
એ હંમેશા યાદ રાખવાનું. ક્રક્સ આટલો છે આ વાક્ય.
Yes.
હા, બાકી જો ડેથ ઇમ્પ્રુવ થતું હોય તો તમારું મોલેક્યુલ ખરેખર ખૂબ
But
સારું.
this is the only meta-analysis which showed it's a neutral on all-cause mortality.
હા,
The
પણ
rest, all.
તમારા બાકીના મેસથી 11-12% થી વધારે કે બહુ નથી.
Nothing.
અને એ ઓવર એન્ડ અબાઉટ સ્ટેટિંગ છે એટલે should be still good, right? પણ હવે I doubt.
So MACE rate in this meta-analysis of 18,000 patients, this is another meta-analysis published in 2022. Similar reduction in MACE rate in patients who are on maximally tolerated statin therapy also has been noted. So this was bempedoic versus statin. Both groups had shown significant reduction in MACE rates.
વર્સિસ હતું કે ઓવર એન્ડ અબાઉટ?
Over and above હતું પણ એમાં subgroup analysis માં versus analysis.
બતાવો એ તો પર્સન્ટેજ બતાતા જ નથી.
એના નથી, એના સેપરેટ ચાર્ટ એ લોકો આપ્યું જ નથી. મેં આખો આ ટ્રાયલ વાંચી પણ જોયું, મેટા એનાલિસિસ પણ નથી.
આમાં મને કાંઈ રેડી જ
નથી. This is a clear outcome trial. એટલે એ લોકો ઉપર clear outcome, clear harmony, clear wisdom આ મેજર ટ્રાયલ લઈને જ કર્યું છે, જે તો ઓલરેડી પોઝિટિવ હતા બેમ્પેડોઇક એસિડ માટે. એનો જ મેટા એનાલિસિસ. એટલે આમાં એટલું બધું સિગ્નિફિકન્ટ ઇફેક્ટ મળવાના ચાન્સ બી નથી. Then bempedoic acid for primary prevention in statin intolerant patient. In statin intolerant patient also, bempedoic acid reduced primary endpoint of 4 composite MACE rates and 3 composite MACE rates significantly reduced with bempedoic acid. Hazard ratio 0.7.
Yeah, 39 મહિનામાં તો this is too much. This is too much.
Only when longer trial was clear outcome, it was done across period of 5 years.
मतलब સ્ટેટિન થી બી તમારે પ્રાઇમરી પ્રિવેન્શનની કોઈ સિગ્નિફિકન્ટ આઉટલાઇન અચીવ કરવા માટે ડિકેડ્સ હોય છે. આ 39 મહિનામાં આટલા બધા
So
પર્સન્ટ
the only major trial is clear outcome.
30% hazard ratio reduction છે અને p વેલ્યુ 0.002 मतलब આ તો એ તો ભગવાન હે.
This is a similar subgroup analysis. So what to do? Should we give bempedoic acid alone or in combination?
નતર પહેલા ક્યારે વાપરવાનું એ કહી દો.
Last slide was, but
એ
I'll
તો
tell you.
સાહેબ બે થી ત્રણ ઇન્ડિકેશન છે.
Main indication, patients who are statin intolerant. Second indication, patients who could not achieve target with statin. Statin intolerance is very less. So practically only one indication.
1 to 2%.
Practically only one indication, patients who cannot achieve target with statin alone.
Statin માં બધું તો statin આપો પછી ezetimibe
હા,
આપો
પછી.
and then
પછી
that is the third one.
એની પર આપણે આવીએ, that is the combination therapy.
તો તમારા રિયલ લાઈફમાં તમારે આ બધા ડ્રગ્સના જ્યારે ઇફેક્ટિવનેસ જોવી હોય ને તો તમે તમારા પ્રાઇમરી પ્રિવેન્શન વાળા પેશન્ટને તમારા પોતાના ઇન્ડિવિડ્યુઅલ ડ્રગ આપશો ને ત્યારે લેવલ ઓફ રિડક્શન ઓફ એલડીએલ તમે જોશો ને then you will realize.
But generally what I have felt કે statin થી જ reduction થઈ જાય છે.
99.99% થઈ જશે. એટલે તમારે જો 50% રિડક્શન ટાર્ગેટ છે કે 70 whatever target you
Below 100 તો statin થી આવી જ જાય છે.
unless and until તમારો heterozygous કે homozygous familial hypercholesterolemia આવે છે એમાં એ LDL 200-250 લઈને આવ્યા હશે.
Yes.
those are the patient કે ટાર્ગેટ અચીવ નહીં કરે. એમાં તમે એઝેટિવે મૂકશો એટલે લગભગ આવી જશે લગભગ.
But homozygous hypercholesterolemia patient getting myocardial infarction is also very less again.
No.
That could be primary prevention માં આપણે વાત કરીએ
હા પ્રાઇમરીમાં તો સારું આવતું નથી આપણા હાથમાં મોટા બહુ ઓછા પણ વેરી
હેલ્થ ચેકઅપ પેશન્ટ જોઈએ ને કોઈક મળી જાય
મળી જાય.
વર્ષમાં એક કે બે પેશન્ટ એવા મળી જાય કે જેનો LDL બિયોન્ડ 200.
બટ તો એના માટે મારી પાસે એક એનેક્ડોટ છે. there is a patient of પેલું connective tissue disorder છે અને statin absolutely contraindicated હતું અને LDL was more than 180 એને મેં ezetimibe આપ્યું. her LDL went to 72 with single ezetimibe.
સિંગલ એસિડ
So that was very much surprised કારણ કે લિટરેચરમાં ezetimibe 50% સુધી LDL ઘટાડે તેવું કે મેન્શન નથી.
30%.
મેક્સિમમ 25 to 30%.
Yes.
બટ એઝેટિમિbe આટલું વધારે ઘટાડે છે મને ખબર નહોતી.
Yes.
એટલે આ તો એનેક્ડોટ છે. આ બીજા પેશન્ટમાં કદાચ ના બી મળે પણ જસ્ટ ટુ સે.
પેલામાં કેમ સ્ટેટિન નહીં આપવાનું?
એ કે ક્રિપલભાઈ ના પાડી હતી સાહેબ પછી હું ડિટેલમાં ગયો નતો.
Myositis હશે.
Myositis polymyositis.
હા, તો આ જ
હા.
એને
Connective
છે ને ડર્મેટોમાયોસાઇટિસ
હા, dermatomyositis.
એટલે ઓલરેડી એને ના પાડી દીધી. અને એકવાર સ્ટેટિન મારા પેલા કોઈ આપી હતી ને એગ્રાવેટ બી થયું હતું સમથિંગ લાઈક ધેટ એટલે ક્લિયર ઇન્ડિકેશન હતું રિપલ્સાનું કે સ્ટેટિન ના આપશો. અને ઓન સ્ટીરોઇડ ડાયાબિટીક એટલે રિસ્ક ફેક્ટર તો દુનિયાભરના બધા.
So when statin is being combined with bempedoic acid, both will have a synergistic effect because bempedoic acid will inhibit ATP citrate lyase, which is two-step above HMG co-reductase enzyme. So this entire pathway can be inhibited by adding statin and bempedoic acid along with. And when all three drugs were combined, bempedoic acid, ezetimibe, atorvastatin, combination reduced LDL cholesterol by 60%. And LDL-C achievement less than 70 could be achieved in more than 90% of patients. But this was not Indian data, this was Western country data. In India, in general, there are no data as such. But statin do reduce it significantly.
So there's a maximum LDL reduction with which statin is intensity.
Each slide, बताओ, baseline में आवश्यक.
અને સિગ્નિફિકન્ટ પ્રીવિયસમાં શું છેલ્લું સેન્ટેન્સ છે? નો એક્સપિરિયન્સ ઓન એડવર્સ ઇફેક્ટ ઓન નો મોર ધેન
So they do not find any significant serious adverse
Even
event with
with
this
triple
triple combination. Then bempedoic acid with ezetimibe. Alone ezetimibe reduced LDL cholesterol by 23%, bempedoic acid by 17%, but when both were combined, significant reduction in LDL cholesterol by 36.2% in combination. ApoB reduction was also significant with all, bempedoic acid alone, ezetimibe alone, and combination also. HSCRP reduction with bempedoic acid, ezetimibe. Ezetimibe reduced HSCRP only by 8%, while bempedoic acid by 31%, and when both were combined together, combined therapy reduced HSCRP by 35%. And this is a very famous slide. Reduction of LDL cholesterol with different drugs, Moderate intensity statin reduce LDL cholesterol by 30. High intensity statin reduce LDL cholesterol by 50%. High intensity statin plus azacitidine reduce LDL cholesterol by 65. PCSK9 inhibitor alone reduce LDL cholesterol by 60%. PCSK9 with high intensity 75. PCSK9 with azacitidine with high intensity statin nearly 85% reduction could be achieved. Versus bempedoic acid alone, it can reduce LDL cholesterol by 30. While in combination, bempedoic acid with atorvastatin with azacitidine reduce LDL cholesterol by 60%. So I would say it's a poor man's PCSK9 inhibitor rather than looking at bempedoic acid. Triple therapy. Triple therapy reduce LDL cholesterol by 60%. PCSK9 alone causes 10 times more costlier than this combination therapy also.
I guess some of the literature do maintain. Some of the literature do maintain that high intensity 40 milligram rosuvastatin can give up to 60% of LDL reduction.
Yes, it reduces. Indian data. Personal experience. It reduces LDL cholesterol nearly as high as 50%.
नहीं 60.
Very rarely we need to add these drugs. Practically. So all picture were rosy. Let's find out some problem with bempedoic acid also. Coming to adverse event part.
रोजी का सोच नहीं.
LDL reduction, HSCRP reduction, mortality reduction, but still it was not being replaced.
I don't know, मैं कहूँ तो ना side effect होते हैं.
अच्छा, side effects.
Like आगे से. मैंने कहूँ तो ना side effect.
So hyperuricemia was associated with bempedoic acid. Significant p-value in majority of trial. Hyperuricemia do occur. Gout. Clinically significant gout in some patients, not all, but still p-value significant. 1.5%. 1.5%. 1.7 hyperuricemia, but gout is 1.5%.
So it is significant p-value,
significant. Liver enzyme elevation, not so significant. Anemia, again it was found to be associated with bempedoic acid.
2.5%.
Unfortunately, it was not significant.
But 2.5% change.
Yeah, 2.5. Still, in placebo group also it was noted 1.6%. But anemia do occur that we need to keep it back of mind.
Placebo and anemia.
No, maximum placebo group में anemia. Maximum HB fall can occur up to 2 grams with bempedoic acid. Tendon rupture has also been found in some patients, but it was not clinically significant. Now, new onset or worsening diabetes mellitus. Significant. In
More than placebo.
yeah,
Less than
more than less than placebo, but yes, it was significant. यहाँ पर भी एक slide है, इन्हीं पर भी आ रही है short time. So bempedoic acid and uric acid percentage change at 6 months is with bempedoic acid 13.9% change versus placebo only 0.5% change. Rate of gouty arthritis 5.6% versus placebo 9.5%. This was another study where gout was not associated with bempedoic acid. So to cross about this bempedoic acid and gout, what to expect? Serum uric acid level may increase by 0.6 mg per person to 0.9 mg per person from baseline. 3.5% of patient may develop clinically significant hyperuricemia and 1.5% patient may experience gout. And about 10% of patients with history of gout may experience gout attack also. How to manage? Patients should be monitored for signs and symptoms of hyperuricemia. When you are in doubt, always check serum uric acid level. And who are at risk? In general, patients who have history of hyperuricemia or gout in past are particularly at high risk when given bempedoic acid.
परसेंटेज एक्स्ट्रापोलेट એટલે ના કહી શકે કે ઇન જનરલ બી કેટલા હાઇપરયુરિસેમિયા ગાઉટમાં જાય ને એક્ઝેક્ટ નથી કહી શકાતું.
નથી કહી શકે. આપણે કરીએ કરતા જ નથી.
અને ક્યારે કેટલા વખત ચેક કરવાના છે?
2 weeks. Anything for anemia also 2 weeks, hyperuricemia also after 2 weeks. કારણ કે 7 days to steady state concentration આવતા જ થાય છે. So after 2 weeks. Patient with hepatic or renal dysfunction, area under curve for bempedoic acid increases with worsening renal dysfunction, so you need to be cautious. Hepatic impairment, bempedoic acid exposure decreased by 22%. Area under curve for active metabolite also decreases. It is safe in general in renal and this hepatic dysfunction, but it has not been studied in patients who are in end-stage renal disease and child class C hepatic impairment. So in these two groups, patients who are in end-stage renal disease and child class 3 hepatic impairment, it should not be given as of now. Now let's look at some fine prints with bempedoic acid. In some studies, it has been found that bempedoic acid reduces HDL cholesterol level, but this major trial published in 2024 did not found any significant benefit in HDL cholesterol level with bempedoic acid versus placebo. So maybe in some patients you will find that HDL-C reduction is there with after giving bempedoic acid, but statistically it is not significant, and clinically also it is not significant. Some rare adverse event like benign prostatic hyperplasia has also been noted with bempedoic acid. The incidence is 1.3% versus 0.1% in placebo group, and this was noted in Clear Harmony and Clear Wisdom trial, not reported in Serenity and Tranquility trial. Serenity and Tranquility patients were on minimal possible dose of statin or not on statin at all, while in Harmony and Wisdom patients were on high intensity statin. So we are not sure whether it was because of statin or whether it was bempedoic acid or whether it was just because of chance. But yes, it has been noted. Atrial fibrillation rate was noted in 1.7% versus 1.1% when compared bempedoic acid along with placebo. Anemia HP can fall up to 2% and it needs vigilance for initial 6 to 12 weeks. Now beyond statin pathway, bempedoic acid also inhibits adenosine monophosphate kinase, and by inhibiting this adenosine monophosphate kinase, it decreases PEPK, it decreases G6PS, this is the glucose pathway, and it reduces insulin resistance. So by hypothesizing this pathway, bempedoic acid should be beneficial for patients who are diabetic. It also reduces inflammation and HSCR. So here comes the controversy of bempedoic acid and diabetes. Risk of new onset diabetes. Now we know that statin, particularly rosuvastatin, do have new onset diabetes. With bempedoic acid, lower rates of new onset or worsening diabetes noted in multiple studies, and that's why it has been hypothesized that bempedoic acid may improve insulin sensitivity and reduce diabetes risk by modulating AMP activated protein kinase activity. Studies published in 2024 in Lancet, when you look at all subgroup analysis at 12 months, patients who were non-diabetic, mean HbA1c reduction was not significant. Normoglycemia almost equal. Patients who are pre-diabetic equal. End of study at 24 months. Similar HbA1c pattern. In another incidence of new onset diabetes, no significant difference has been found. So this was the only larger studies we particularly compared bempedoic acid versus placebo in terms of increase in HbA1c level and diabetes, but they did not find any significant.
This was on the background of statin or without statin?
This was with statin. Now, few patients were without statin, but majorly patients were on statin. They have not specified whether they were on high intensity statin or moderate, but they were on statin.
The point here remains that statin is extensively studied, and once you give any lipid lowering molecule in primary prevention, that means that those patients are the younger generations. બરોબર હવે એને તમે decades માટે follow કરો, so it is very logical that many of them might develop diabetes in future. You cannot directly relate that to statin.
Yeah, that's why we have robust data with rosuvastatin.
So that is why every now and then, after 2, 3, 4 years, diabetes and statin study comes.
Yes,
Some
yes.
agrees, some disagrees, some agrees, some disagrees. Right?
Yes.
But there is no strong correlation.
No strong.
It is established.
It may be because of chance or it may be because of lifestyle changes also.
So if we start giving bempedoic acid from today itself from primary prevention to everyone, in next decade you will definitely find, oh, diabetes incidence is increasing on bempedoic acid as well, right?
Then some studies have also showed that diabetes incidence is there with bempedoic acid also.
Yeah, but it is still very less and the noise level is less.
Because by now hardly any patients, if you compare global population, hardly 0.5% patients are on bempedoic acid. So we could not comment. Bempedoic acid and metabolically associated steatotic liver disease. This has also been newer hypothesis. that bempedoic acid improves metabolic milieu by reducing gluconeogenesis, by rate limiting enzyme of fatty acid inhibition, and rate limiting enzyme of cholesterol pathway inhibition. So in general, it has beneficial effect on liver, and it can be used as a therapeutic agent for NASLD, but further trials are required in this area. What about guidelines? Guidelines directly do not have any mention of bempedoic acid, but when you look at in between the lines or read in between the lines, ESC 2024 guidelines, it said that patients who do not reach their goal on maximally possible tolerated statin therapy and ezetimibe, a combination of bempedoic acid should be considered. Class 2A indication, level of evidence C. It's not very strong recommendation. Another guidelines by lipid expert panel published in 2024, they also included bempedoic acid at second stage. First stage was moderate to maximally tolerated intensity statin with ezetimibe. So bempedoic acid was added after ezetimibe in this guidelines also. 2025 ACCHA guidelines, they do not mention bempedoic acid, but they mention that patients who are not tolerant to statin, a non-statin LDL lowering therapy can be added. Non-statin LDL lowering therapy includes ezetimibe PCSK9 inhibitor as well as bempedoic acid. So no direct mention of bempedoic acid in ACCHA guideline here.
So that was clear for acute coronary symptoms subgroup.
Acute coronary, this was for ACS guidelines. This was not a primary prevention guideline. Primary prevention guideline, by now there is role of statin and ezetimibe, nothing else. So to conclude, bempedoic acid is a novel oral non-steroidal, non-statin lipid lowering agent. It inhibits ATP citrate lyase. It lowers LDL by 17 to 28% in various studies. It's well tolerated and favorable safety profile, especially beneficial for patients who are statin intolerant and patients needing additional LDL lowering despite statins. So this was all about bempedoic acid. Very short topic, but long slide.
તમે કેટલા પેશન્ટના આપી શકશો?
हाँ सर.
તમારો કઈ સ્લાઇડ મોકલી એના વિશે કોમેન્ટ કરો.